The National Hispanic and Latino Mental Health Technology Transfer Center was established to develop and maintain a collaborative network to support research development and dissemination, training and technical assistance, and workforce development for Hispanic Latino populations and communities receiving mental health services throughout the U.S. mainland and the Caribbean. We offer free technical assistance. If you want more information, please contact us. The National Hispanic and Latino MHTTC is under the direction of the Institute for Research, Education and Services in Addiction, IRESA, and housed at the Universidad Central del Caribe School of Medicine in Puerto Rico, and supported by the Substance Abuse and Mental Health Services Administration, SAMHSA, of the U.S. Department of Health and Human Services. As mentioned, the Mental Health TTC network is funded by SAMHSA. SAMHSA strives to reduce the impact of substance use and mental health disorders on U.S. communities throughout its programs and services, and demonstrates that behavioral health is essential to health. Prevention works, treatment is effective, and people recover from mental and substance use disorders. You can learn more about SAMHSA by visiting www.samhsa.gov. And now our moderator.
Hi, everybody. Welcome to today's webinar. I would like to introduce our presenter, Dr. Roberto Luis Fernandez. Dr. Roberto Luis Fernandez is Professor of Clinical Psychiatry at Columbia University, Director of the New York State Center of Excellence for Cultural Competence and the Hispanic Treatment Program, and co-director of the Anxiety Disorder Clinic at New York State Psychiatric Institute. His research focuses on developing culturally valid interventions and instruments to enhance patient engagement, reduce misdiagnosis, and help overcome disparities in the care of underserved cultural groups. He also studies how culture affects individuals' experiences of mental health disorders and their help-seeking expectations, including how to explore cultural variation during the psychiatric evaluation. Dr. Luis Fernandez led the development of the DSM-5 Cultural Formulation Interview, a standardized method for cultural assessment for use in mental health practice, and was the principal investigator of its international field trial. Dr. Luis Fernandez's research has been funded by U.S. federal and state agencies, as well as private foundations. He has published over 200 articles, editorials, commentaries, reports, books, and book chapters on the topic of cultural mental health. He is chair of the Cultural Committee of the Group for the Advancement of Psychiatry, president of the World Association of Cultural Psychiatry, immediate past president of the Society for the Study of Psychiatry and Culture, and past president of the American Society of Hispanic Psychiatry. He was a member of the National Institute of Mental Health National Advisory Council and chair of the DSM-5 Cross-Cultural Issues Subgroup. He chairs the DSM Review Committee for Internalizing Disorder and co-chairs the ICD-11 Working Group on Culture-Related Issues. He has received numerous awards from the American Psychiatric Association, the National Association for the Mentally Ill, and SSBC. He was educated at Harvard College, Harvard Divinity School, Yale Medical School, and the Cambridge Hospital Harvard Medical School.
Thank you very much, Daddy, especially for such a nice introduction. The talk today, the webinar, is about the DSM-5 Cultural Formulation Interview, its overview and recent developments. I will try to cover a fair amount of material, but I will try not to rush. Next slide, please. So this is the outline for the presentation today. First, we're going to talk about what culture is, then the development and content of the Cultural Formulation Interview, research with this instrument, implementation issues, and future research directions. Next slide, please. So what is culture? Next slide. This is a very difficult topic to summarize briefly. Next slide, please. Right. And here what you're seeing is the definition of culture that we included in DSM-5 as a way of summarizing, as I was saying, a complex topic. Now, the key issue to remember is that culture is a process of making sense of the world. So it isn't only a set of characteristics in a static kind of way, it's actually more of a method, a way in which people make sense of what they're experiencing and provide meaning to it, including illness, health, healing, anything related to the kinds of work that we do, social difficulties, any kinds of work that we do with mental health related issues and development related issues. So everybody in that sense has, quote, culture, in the sense that everybody inherits a set of ideas, traditions, ways of making sense of the world that comes from their participation in certain social backgrounds. So for example, people of a certain age in a certain place, for example, tend to share a way of looking at the world that may be a little bit different from people who are much older than they are, who have shared in some ways some things in common. At the same time, gender makes a difference, sexual orientation, education levels, race, ethnicity, language, religion, even your profession, the sort of things you've dedicated your life to, any number of social groups that you've been a part of, whether you've been in the military or not, all of these affect how you look at something like mental illness or a life problem. And so we are interested, when we talk about culture, in talking about the influence of all those social backgrounds, not only one or another. And in that sense, everybody, even the people with the most money and the most power, also have a cultural background that is affecting how they look at the world. And in this case, when we're looking at the cultural formulation interview and its use, what we're interested is in finding out what the person thinks of their condition, their problem, how they define it. You will see the parts of the CFI very shortly, but we're interested in how their connection to their backgrounds and their identity pattern make a difference for the way they understand these things. And so the DSM-5 has this list here of values, orientation, knowledge, practices, essentially a way of making sense of the world, aspects of the person's background, experience, and social context that affect their perspective. I was just explaining that. And then in particular, we focus in the CFI on the influence of the family and their more closer friends, because that is the context, the environment in which culture makes its biggest contribution. We spend most of our time in the world in families, and those have their own interpretations of the world. Next slide, please. This slide is here to remind us that much of this awareness does not happen consciously. Much of how culture influences how we look at the world happens out of our awareness. We, like in this sense, fish don't know they're in the water. We forget the air we breathe. This is a reason why anthropologists, the professional students of culture, tend to go study culture somewhere far away, not because those people have culture and we don't, but because the culture of the anthropologist's own hometown is much harder for the student anthropologist to learn than a place that is very, very different, where they are obviously faced with a lot of reasons why they don't understand what's going on. So this is the idea here, that we have to remember that it's not possible to simply ask someone, culturally, what do you think about your illness or about your care? Because that is a very difficult question to answer. If somebody asked you this question, you'd find it very hard to answer, even if you'd spent a lot of time thinking about it. Certain things are easy to pick up or to say, like if, for example, you have dietary preferences or any number of other things, but most of the more complex things are hard to explain. And so how we do it is that we ask questions about the person's views and then try to hear within the questions the answers that have to do with their own background. Okay, next slide, please. So we're going to talk very briefly about the development of the cultural formulation interview as it made its way into DSM-5. Next slide, please. So any systematic cultural assessment should follow these 6 descriptives here that I've put on the list. It should be comprehensive in the sense that it should cover everything in sufficient depth, all the topics. It should be thorough, comprehensive in that it should cover all of the relevant topics, thorough in that it should cover each of them in the appropriate depth, standardized in that it should be systematically able to be repeated, skills-based in that it's something that should be learned as opposed to just naturally you're a member of a certain group so you understand what the person is saying. It should be possible to actually acquire knowledge for how to administer an instrument. It should be educational in the sense that the more you do the CFI with people, the more you learn about the different kinds of people and their backgrounds, and the easier it is to do. And it should be person-centered rather than group-based, so that in fact you know about what that person thinks rather than what you imagine that person's whole group to be. And this is an important element because culture is very, very focused. People have their own interpretations of all their backgrounds. So nobody is just a stereotype. Everybody is different. Even if they come from a particular group that you think you understand, they may have a very different view than many of other members of that group, an age group or a gender group or a whatever group. So it's important for any cultural assessment to be these things. Next, please. So the roots of the CFI come from the outline for cultural formulation, which I will describe in a minute, that was in DSM-4, and it was a narrative way of describing what are the components of a good cultural assessment, and I'll mention those in the next slide. But then what we did is take that and add to it a lot of other considerations that was connected to that are listed here. For example, a biopsychosocial approach, this person-centered care, the fact that I mentioned, the fact that people should make decisions together between their clinicians, their providers, and themselves, the cultural humility element in the sense that we shouldn't pretend to know everything about somebody else's culture. We should need to ask and be told about things rather than assuming them and thinking we're experts in somebody else's life. All sorts of reasons, roots, as you see here, that are important. Next slide, please. Next slide. Yeah, so this is the cultural formulation, the outline that was in DSM-4, and these are 5 domains that the outline described narratively, meaning there was a little text that said you should evaluate the cultural identity, and it's important to realize that migrants have a cultural identity from the culture they come from and a cultural identity in the culture they're in. So a few guidelines about how to do this at all these 5 levels, but there was no instruction about how to turn these narrative descriptions into actual questions, which is what then we did in DSM-5. We kept the outline for cultural formulation, tweaked it a little bit, but then added the question part, the cultural formulation interview, that's in the form of a questionnaire, an open-ended set of questions. You'll see them when we get to them, that actually enables the person to actually implement the outline for cultural formulation. Next slide, please. So these are the goals of the cultural formulation interview, because it's important at this point to stop and say, why are we doing an assessment like this? Why do we want to know about cultural background and cultural expectations of care and so on in terms of, psychiatric, psychological, social work practice, counseling practice? And these are the goals of the CFI. It's important to get the person to describe their story, for us to know not only the diagnosis a psychiatrist thinks, or the set of internal cognitive processes, or whatever technical thing our profession guides us to look for, which is very important, but we also want to allow the person to tell their narrative, because it really not only empowers the person, which is one of the goals you'll see down below in a minute, but also actually provides a lot of information that you can find useful during diagnostic process or evaluation process in general, and the definitions of clinical care. We want to know what meaning they make of their illness or their predicament, and we want to figure out how they call things so that we can include that in our assessment when it comes to asking about things, and I'll say more about that in a minute. Next click, please. So we also use the CFI in order to tell the story so that the person feels like they're being heard, and that way we can increase rapport and trust we actually, not only they feel they're being heard, we hear them. And this enhances the alliance with the person. Also, it tells us a lot about how the person sees what's going on, and this helps us align the treatment with the person's expectations. Next slide, next click, please. And also, it evidences caring. One of the more interesting aspects of research that we found is that just by asking the questions, people felt cared for, because we evidence caring by asking, inquiring about their perspective. And then a few more things I already mentioned. Empowerment. What counts as evidence here is the idea that the person's subjective experience is almost or more important than our observations as clinicians of what's going on. Next click, please. So this is the development. In the interest of time, I won't spend much time on this, but we essentially took the outline for cultural formulation. We subjected it to a series of steps to turn it into questions. We developed an initial draft of those 14 questions that were as at the time. We did a very large field trial. You see some of the results. And we analyzed it and then revised those 14 questions into the 16-item final version that made it into DSM-5. And we're working on subsequent research since then. Next slide, please. Here is just an illustration of the kind of research that was done before. I won't have time to describe it in detail, but the idea is that the outline for cultural formulation had been operationalized by different groups. You see the countries up on the right corner around the world since DSM-4. They came out, the outline came out in the appendix of DSM-4 in 1994. And DSM-5 came out in 2013. So in between, different groups had taken the narrative description of the outline in DSM-4 and turned it into a series of questionnaires. And what we did, we included most of those people in our committee that developed the CFI, most of the people who had worked on it in the intervening years, and we did a literature review. The references are below. A literature and the reference right below the title, where we looked at what they included and made sure to include those topics in the CFI. This is the example for cultural identity. Next slide, please. So the CFI can be used with any patient in any setting by any clinician or provider. And the idea is it's, however, hard to do with every single person just in the interest of time, though we recommend it because we think it's useful for care generally. But there are certain cases where the CFI we think is especially useful. And these are when you really don't know how the evaluation is going because it's hard to understand what's going on because of cultural differences or cultural misunderstandings. And either that complicates the assessment or it's unclear how the symptoms fit with the categories, or there's difficulty in judging severity or impairment, or there's disagreement about what to do in terms of treatment or care more generally, or there's problems with engagement and adherence. These are points at which it is useful to use the CFI. Now, the CFI we recommend to be used at the very beginning of an evaluation, meaning to start by doing the CFI. It's like getting the person's full story first. And I'll tell you in a few minutes how long that took in the field trial. And then once the person has told their story, then we follow up with our own questions to flesh out and clear up the answers that the person has given, and also for us to reach the particular questions that we as part of our evaluation think are important or are mandated to ask. But the CFI can also be done at any point in care. That, for example, here, this gives an example of when there's already some treatment been going on, but the person is having some difficulty engaging with the clinician or the clinician with the patient. There's some misunderstandings going on or some other difficulties. And the CFI can be used as a way to clarify the situation. I just got an email this morning from one of the residents here at our program in Colombia who had asked to meet with me a couple of weeks ago about a patient she'd been seeing for a while, but with whom the person came from very far away, another country, and she felt that there was a substantial amount of information she wasn't getting. And so we discussed using the CFI. She went and did it and feels that at that point the person raised some issues that she didn't know were important, that although she'd been seeing him for months, he was able to answer the questions in ways that are useful. So it can be done at any time. Next slide, please. Now, what does the CFI consist of? Next question. Next slide. This is the general outline of all the components of the CFI. There is a core CFI, That's there in the central circle on the top. That's the 16-item version that I'm going to spend the rest of the time talking about, and it's the basic assessment. Basically, it's the assessment that you would use as the first part of the CFI you would use, generally speaking. However, there's an informant circle, it's informant version in the circle below the core CFI, and that version is to be used with people who are not the patient themselves, a relative, a friend, somebody who's giving collateral information. Perhaps the patient is too young or too sick or to give information, so you ask an informant about the person's views. But what you're asking about is you're asking the informant to tell you what the person would say. Then there are supplementary modules that can be used to deepen the assessment, and I'll give you an example of that during the talk for cultural identity. And those are ones that go into the sections of the core CFI, but in more depth if you want more information, or that ask about particular subgroups. For example, there's one on elderly patients, one on school-age youth and adolescents, like that. Next slide. This is what the CFI looks like on the page in the DSM-5. There's the right-hand column are the questions and probes and introductions that you would read or put in your own words to say to the patient to ask. And then there are instructions in the left column in italics that tell you what each question is getting at, so that if the first way you ask doesn't produce an answer, you're not lost. As a provider, you know what you want to know about by reading the instructions on the left tells you what you would need to ask about. So we worked hard to make the questions understandable, but it's quite possible that the person doesn't understand or you have a better way of doing it. And so we encourage people to put it in their own words so that they can make sure to have a good rapport with the person and get the information that is asked of every question. Here you see that there's an introduction with some instructions that normalizes the questionnaire, that says there are no right and wrong answers, you're the expert, we want to know what you think, that kind of thing. And then there's the first domain. You will see that the CFI has 4 domains, and I will go through them in some detail. But this is the first domain that has 3 questions. You see questions 1, 2, and 3, and I will go through them as I go along in a minute. Next slide, please. Click again till you have all 4 domains. Thank you. Here you have the 4 domains of the CFI. I will now, they're all one after the other. You see there's 16 questions. I will now go through the domains in the next slides. But so you see structurally, there's 4 colors, right? The first domain is the cultural definition of the problem. In that domain, you want to know what the person thinks is going on, including how they talk about it with their social network. The second domain has to do with cause, context, and support. What makes it better? What makes it worse? What caused it in the first place? What precipitates it? And also, what is the role of cultural identity in all of these processes? The third domain has to do with the past, help seeking and coping. What did you do before to cope on your own or to get help from people, and what got in the way? And the fourth domain has to do with what do you want to do now, and how is the relationship between the provider and the patient going to affect that? That's the general structure of the CFI. You see what kinds of questions are being asked. And the advantage of seeing them at all in this way is that you may get a sweep, in some sense, a sense of the narrative arc that is being asked about. What is it that you want to know? What sorts of things? What you're having is a conversation with the person, and you can probe, you can follow up questions. There's no reason why you can't get more information. You can go through it quickly and parsimoniously, but you can also stop in a given subdomain and ask more questions about that. But the idea is to always ask open-ended questions that get the person talking about what they think is going on, rather than then derailing the conversation away from the person's story into a major kind of assessment on something else. For example, if the person talks about suicide, this is most of the time likely not the moment to start asking detailed questions about suicide. You can return to that, but in this assessment at the beginning, you just want to note that the person may be suicidal. You want to hear the story and the meaning of what it means to the person to possibly be thinking about suicide and so on. And then later you will ask the questions right away. I'm not saying to put it off in the same interview. You would then, after this narrative part of the person's story is over, you would come back and you say something like, it's important what you told me about suicide. I see you're feeling very badly. I'd like to know the following things. Do you have a plan? Do you intend to do it? Have you done it before? All the questions that you ask about suicide. But if you stop in the middle of the narrative story and start asking about suicide, the interview becomes one that you're concerned about, obviously for good reason, but it stops being an interview and a conversation about the person's own interpretation of things. Okay? And I'm happy to take questions about that later. Next slide, please. So now we're going to go through the domains. The first one is the cultural definition of the problem. It has 3 questions. One subdomain, cultural definition of the problem, meaning this domain, every domain is divided into subdomain. This is the one domain that only has one subdomain, also called cultural definition of the problem. And the 3 questions are essentially a very general open question about what brings you here, a probe about, it's possible for doctors to agree or disagree. We don't have to always say the same thing, because sometimes people just tell you what they think you want to hear, and it's okay for you to say, well, I understand you have schizophrenia, and that might be how they see it. But, how is it that you describe this, but doctors and patients don't necessarily need to agree. You may have other views. And also the second question is designed to bring those views out by asking, well, how would you describe your problem to your social network? For example, the idea is, how would you tell your grandmother about what's going on with you? And this is a way in which it would get other explanations, if you will, besides the biomedical one that people might be more thinking you want to hear about. And the last question in this section has to do with what troubles you the most. Next click, please, has to do, if you click again, one more click. Okay, there. The question about the social network, there are 3 questions in the CFI that relate to the person's family, friends, and others in the community, and this is one of those 3 questions. What is it? How is it you explain your problem to them? And from this first domain, the provider would get a sense of what's going on, and also what language the person uses to refer to it, because you will take that language and you will use it later in the CFI as a way of referring to where in the CFI it says problem in brackets. So, for example, it takes schizophrenia, the example I was using. If the person doesn't call it schizophrenia, but says, I feel really bad because everybody is after me, then you would actually use that language and you would say, what are the causes of you feeling really bad that people are after you, rather than what are the causes of your schizophrenia. You would use the language that is nearer to the person rather than distant to the person. And research has shown that if you do that, the person is much more likely to engage in treatment. Next slide, please. Click again, please. Thank you. This is the second domain that has 2 subdomains. The domain is cultural perceptions of cause, context. 3 subdomains. Cultural perception of cause, context, and support. These are the first 2, causes and stressors and supports. The first one, causes. We want to know what they think has caused the problem. And we also want to know what the person thinks, the social network thinks that's caused the problem. My mother says, I'm depressed because I married the wrong guy, and I should just I made my bed, I need to lie in it. It's important to know that when you're going along with treatment and so on. The second domain there has to do with what makes something better and what makes it worse. And here is where you can find out a lot of issues around discrimination or any other kinds of problems that might be affecting our poverty, any number of problems that can be affecting our community and social determinants of mental health, for example. Next slide, please. I'm sorry, go back. There's one in between. Click back, please. Yeah. Okay, apparently there's a slide missing, which has to do with cultural identity. And this is the third subdomain of the cultural perceptions of cause, context, and support. It seems to have been left out, or by technical reasons it's not showing up. No worries. That has 3 questions. The first one defines what cultural identity is, a rather longish introduction that we felt through the field trial was very important to define what culture is, similar to what I said at the beginning of this talk about culture being any number of influences from your background and a sense of meaning and so on. And then we ask three questions. The first one is, what are the most important aspects of your background or identity? And it might be different than you think. You might think it's the fact that they are super religious, when in fact it's not that they're super religious, it's that they have a particular, they're a nurse. And being a nurse is much more important in their thinking at the moment than being super religious, or any number of other possible. You may be wrong in your assumption about what's more important at the moment. So that's the first question. The second question has to do with how their cultural identity, these aspects, make a difference, for good or for bad, in their current situation. And the third question has to do with any other problems that may be related to their cultural identity, or problems or concerns of any kind. So these are the three questions that are still part of the second domain. Next slide, please. The next, one more click. Thank you. The next domain, no, one before. Yeah, thank you. This, I mentioned, has to do with the past and what they've done already to cope with the situation, and what helped and didn't help in past help-seeking sources, because it might be that they have tried different things already that you're about to offer them, and it'd be very good to know that they tried them and they thought they were wonderful, or they tried them and they thought they were the worst thing in the world. It's much better to know that in advance, and in particular to get some detail about why it worked or it didn't work. The third question here has to do with barriers. What are some of the things that get in the way of their help-seeking options? They really would have liked to have received daily psychotherapy, but they couldn't afford it, or any number of other things. These are, and we give them examples there of the barriers, but you can also tailor them to your particular community. Next slide, please. Now, this is the fourth domain. The first three domains were the cultural definition of the problem, the cultural aspects of cause, context, and support, and the past help-seeking and coping. Right? Those were the first three domains. What's going on? What causes it, makes it better in its relationship to cultural identity, and what have you done already? The fourth domain has to do with what do you think we should do now? And it has two domains, subdomains. One is preferences, literally, what do you think would be most helpful at this time? And also, what do you think your social network is suggesting? Again, this is another place where we ask about the social network, family, friends, and others in the community as part of the CFI. And it's the third of the three times we do that. And here we ask what other help they suggest. My family thinks I should go to church more. If only I prayed, everything would be better. This is important to know in terms of the kinds of relationships they have with their family, what other ideas the person themselves may have, what other coping mechanisms and healing systems they may be accessing, and so on. Next slide, please. This is the last the last subdomain of the CFI, and it has to do with the clinician-patient relationship. It's question 16 out of the 16, and it's a question where what we're asking is anticipating any misunderstandings or concerns between the patient and the clinician. For example, there's this introduction, sometimes doctors and patients and you can substitute any therapist or provider there. Sometimes providers and patients misunderstand each other because they come from different backgrounds or have different expectations. Have you been concerned about this, and is there anything that we can do to provide you with the care you need? And the idea here is that we want to give the person the opportunity to say their concerns right off. I'm a woman, you're a man, I'm not quite sure you'll understand me. Or, as many of our population do, they don't answer anything at this point, but they hear the fact that you're open to knowing about this. And so later, when they have more trust, more confianza in what you are about, they might say, remember, a bunch of weeks ago you said that question, and I thought it then, I didn't want to tell you, but in fact, I've always been worried about this. But now I see X, or I'm really worried about it, or whatever. So this is the CFI. These are the 16 questions that we're proposing people ask at any point, but we recommend to start treatment with these, evaluation with these questions, and then to incorporate it in the treatment planning, the decision-making, the choice of treatments, a way of engaging the person more. If it works well, people would keep referring to this in the course of therapy as information that would be useful, and may actually go back to it at different points to clarify things or get more information through the supplementary modules. Next slide, please. So I'm going to go through these slides more quickly in the sense of in less detail for each one, merely in the interest of time. There is that informant version that I mentioned. You have this information here if you want to examine it. All of these CFIs are available for free on the APA, American Psychiatric Association website. If you Google DSM-5 CFI, these should come up, and we give you those links anyway as the last slide in this presentation. Next slide, please. There are supplementary modules. These are the 12 of them. Click, please. There is this one on cultural identity. I'm just illustrating. Another click and another click. Thank you. These are some of the contents here of the cultural identity module that spell out more questions in detail about national, ethnic, and racial background, language background, migration background. Next slide. And here also spirituality, religion, and moral traditions, gender identity, and sexual orientation identity. So you see how it's fairly comprehensive, and it attempts to ask about different aspects of cultural identity. I'm sure there are other aspects that are not included. I know there are, but we also have a limit as to how many questions one can put in DSM-5, for example. Next slide, please. So research on the CFI, rather quickly too, but general, next slide, please, general information. Another click and another click. Thank you. We did a field trial with over 300 patients in 12 cities and 6 countries. It was a very large cultural psychiatry field trial. And where our aim was to take the developing CFI that we had, the first draft we had, and see whether it was feasible, acceptable, and considered useful by patients, clinicians, and relatives. And what we wanted to know was, feasibly, did people think, could clinicians feel that they could do it? Do patients answer the questions? Did patients understand them? Acceptable, did people like them? And useful, how useful did they think it was for a range of different options? Next slide, please. This is the map of all the parts of the world where we did the field trial with American Psychiatric Association support. Next slide, please. And the design was that we trained interested clinicians in the CFI using this method. I'll say more about training later. And then we asked them to see new or existing patients. The different sites had different rules because of their own realities, what was possible at each site. And these were always patients, however, whom the clinician did not know. The clinician never interviewed their own patients. And then each clinician, and this is important to realize, interviewed at least 3 patients. That was our goal, and sometimes 6, fewer, 4, 5, 6, even sometimes more. The idea being that we weren't just asking clinicians about the first time they used the instrument, which is always the hardest time, but we let them try it over a period of time to see how it changed. And I'll show you those findings. Next slide, please. So this is the main slide. The main focus of this slide is essentially, let me just tell you what it says. You have the graph there. But essentially, the green group are the clinicians and the purple group are the patients. And you see, I'm happy to say that the patients always thought the CFI was better, more feasible, more acceptable, and more useful than the clinicians. I'm very happy about that the patients were more positive about it than the clinicians. However, you see that it's just a matter of degree, because everybody agreed that it was feasible, acceptable, or useful. It's just that the patients had a stronger response. Now, what the colored letters mean is that the clinicians were concerned overall about feasibility. How feasible is it to add these 16 questions to a busy practice? And what you see here is the sum of all their answers. So I'll break them down by how many times they've done the CFI in a minute, but this is the average. And what you find is that the clinicians were more concerned about whether it was feasible than the patients. The patients were not concerned about this. And the clinicians were more concerned about it being feasible than they were concerned about it being acceptable or useful. They thought it'd be acceptable or useful. They were just a little bit more concerned about it being feasible. Next slide, please. However, what this slide shows, and I don't I don't show you the other slide with the feasibility, acceptability, and utility data, but this is the same format, which will help me explain that and will also give you more information on something else. What this shows, this busy slide shows, you see 6 sets of columns, one purple and one green. What this is the administration of the CFI by the clinicians. So the first time they did it, says first below, the second time they did it, the third time they did it, and so on, up to the 6th time. Now, more people did 1, 2, and 3 than did 4, 5, and 6 because everybody was required to do 3. But you still see the same pattern, and it's what happened to feasibility as well, which is that over time, people get used to using a new instrument. And so what this here shows in the purple is the number of minutes that it took people to do the CFI questions. The clinicians took the clinicians to do the CFI questions. And what you see is that over time, as you go to the right, the number of minutes decreases. It goes from 26 to 22, and it stays around 22 for the entire time. And the green is the number of minutes of the whole interview. We asked them to do the CFI at the beginning of their professional, whatever their discipline was, evaluation. And you see that at first it took slightly over an hour the first time they did it. But by the last time they did it, they were able to incorporate the CFI in a 50-minute interview. So essentially, they kept the CFI duration the same. They didn't skip questions. They didn't think it wasn't useful, but they did it all. They were able to shorten their session overall. And the idea there, as we understand it, is that the CFI questions enable you to ask a lot of the same information you would ask in a regular evaluation. It just asks it from this point of view of a cultural background perspective. So you ask about past help seeking, and you ask about family stuff and so on, and something about what's going on and symptoms and causes and so on. But you ask it in a way that is open-ended. It involves the views of the social network, and it asks them for their own interpretation of things. So you get a lot of the same information, and in addition, you get cultural information. So that is, or cultural focused information. So this is why we think people are able to do the CFI in shorten the overall interview, but still retaining the CFI 22 minutes. And what we found for feasibility is that after one administration, there was no longer any difference in the views between feasibility, acceptability, and utility. Basically, the clinicians felt after one time of using it that the CFI was as feasible as it was acceptable or useful. Whereas overall, because of the difference here in the first visit, the average had shown a difference for feasibility. Next slide, please. I'm going to skip this slide in the interest of time. Next slide, please. And actually, go back one slide, please. Go back one click. Thank you. I'll just mention about this that my colleague Neil Agarwal did a qualitative data study about their open-ended answers, about asking patients and clinicians after the interview what they felt the CFI was useful for. And they were slightly different. The patient answered, the biggest answer was around rapport. They felt the patient to feel better in their relationship with the clinician. The clinician particularly answered about eliciting the person's perspective and enhancing communication and understanding of illness. But you see and you see the question there, the next to last one, about caring. That was an unexpected one, how people felt the questions expressed care. Next slide, please. I'm going to skip this slide. Next slide. Right. And in terms of implementation, we have a fidelity instrument that allows for research purposes or supervision purposes to measure how well the person is administering the CFI. Did they ask all the questions? Did the patient answer in relevant ways? Were answers followed up until they were relevant? That kind of thing. So we have a method for assessing whether it's being used with fidelity. Next slide, please. And a lot of the questions that people come up with have to do with whether it can be used with patients with psychotic disorders. And the answer is still uncertain. It seems like if the person is very psychotic, then it's very hard to do an interview where you ask the person's opinion about things and their meaning making and so on. They may answer, but the answers may be very hard to interpret. But it can be used with chronically psychotic persons, as this study showed. One more click, please. And another click, please. Thank you. Right, which is a study of 14 veterans in a U.S. VA hospital with 14 men. Most of them were men, and basically they felt that the CFI here under thematic analysis says that it was like talking to a friend. They felt it helped them dig into their ideas and open up, and that they themselves got insight into things by talking about the situation. This was a similar kind of analysis of open-ended debriefing questions after the interview that we did that they did. I helped supervise this, but this is the work of Angela Muralidaran in Maryland, that essentially asked patients about their views about the CFI, and this is what they found, that it helped to enhance rapport engagement, even though all these patients had a psychotic disorder. Next slide, please. So it seems like in some ways it depends how psychotic the person is and whether they're able to contribute to their care by making sense of the situation. So it might be that when they come in to a hospital setting where they're very psychotic, you might need to wait a little bit. We're finishing up a study now where the clinicians argue for that specifically, maybe not at the very beginning, but wait until they're a little bit more, recompensated and then ask these questions. So in terms of training, there are different ways of doing training. Some are more passive, like just reading the guidelines or watching a video. Some are more active, like doing role plays, doing coaching and feedback like that. So there's different ways of train in the CFI and in other things. Next slide, please. And so my colleague Neil Agarwal again led this study, very nice study, of the preferences in the field trial about the methods that we used in the field trial for training on the CFI. But there have been other studies. Stacia Mills and others have done research on Auralid Padilla from Puerto Rico also did a nice study in Massachusetts about ways of training people. Russell Lim and Francis Liu, different people have been focusing on the training element. This is one study that we did with the data from the field trial, and what it shows in the orange is what was most helpful. The blue is what was least helpful of the other different training modalities we used according to the 75 clinicians in the field trial. The clinicians really like the role playing. They think that's a very good way of learning the CFI. They like the mix of passive and active methods, watching a video and doing a role play. But in some cases, some people, the video had some difficulties relating to, whereas the role play was most helpful. Next slide, please. So in terms of training, actually, I can't stress this point enough. There's interesting work from Mexico. Different countries are using the CFI. This is work in Mexico. People in the Nordic countries, Scandinavia, are using the CFI and studying it a fair amount. Sweden, Norway, Denmark. But here, this is a study from Mexico, and the bottom line of this study is that they gave residents, psychiatric residents, just the written instructions from DSM-5 and said, here, apply this. And what they discovered is if the residents didn't already know what is meant by culture, they really had a hard time understanding the cultural identity questions. They kept misunderstanding, thinking in this particular setting in Mexico, that culture only applied to being an indigenous person, being an Indian of some kind, would be the right answer for being cultural. Any other answer, like not being somebody of indigenous background, as though those people didn't have a culture. And so this was a misunderstanding that some of the residents had that needed to be explained, or they would be administering the CFI in an unuseful way. Next slide, please. Yeah. And but they still found that the CFI in general was useful, obtained useful information on social support. It helped the diagnosis, treatment plan, and the patient-provider relationship. And that's what I said about provider culture and training. It was the providers who already had a social science background, had studied that in some other career or studied it in college before going on to medical school. Remember, these are all psychiatric residents. They understood the questions, but a lot of other people, the question on culture, but a lot of people didn't quite get the idea of culture. They applied their own previous understanding that wasn't very helpful. Next slide, please. So we have other training resources. This is a module that we've developed here that is available worldwide. Here are the links in case you want to learn, use it. It's a 1-hour training module that has CME medical education credits all over the United States and Canada. It has social work and counseling, I believe, credits in the state of New York, where we developed it, but not elsewhere, unless you can apply the New York credits to your state or country. But essentially, we're very proud of it because it's four of them are pictured here, five care recipients with lived experience of mental illness who are well along in their process of recovery, and as part of that process volunteered to describe themselves, to discuss their history, answering the CFI questions in a way that was very illustrative for how to use the CFI. Next click, please. We'll show you, basically, it illustrates how to use the CFI. Next click, and it's about an hour long, and it's available, as I mentioned, and it has these action planners. Next slide, please, details this. Another click, and another click, and another click. Thank you. These are the contents of the module. I won't go through in detail for lack of time. I want to leave some time for questions. You have this in your handout, or in I think these slides are available. I certainly hope so. And it essentially illustrates the different ways that we train people using this module. Next slide. There's also a book. There's also this. Before we get to the book, there are videos that we've developed with young people also describing their stories. These are, however, actors who are portraying those stories, people with early onset psychosis, early onset psychosis, that's right, who are describing their views of their situation following many of the concerns, many of the items and questions from the CFI. And these will be available very soon. Some are already available. They'll be on YouTube. And they're essentially ways to reach youth so that they feel able to answer this kind of questions and also see the importance of them telling their story as part of the CFI cultural assessment process. Next slide, please. We also have a book that's available from American Psychiatric Press. If you're interested, shameless plug for our book. We don't make any money on it at this point. Next slide, please. So future research directions. This is almost the last slide. Next slide. Essentially, we still need a lot of work. I've shown you much of the research on the CFI. I skipped a slide that summarized others, but essentially, that slide that I skipped showed different work my colleague Neil Agarwal, I mentioned before, for example, is doing on turning the instrument, the 16-item tool into a process, a 3-session process for obtaining better engagement, for developing better engagement between the patient and the provider. So there are different research going on. So we still need information on what is the best training practice, how does care improve when we use the CFI? We've developed the CFI, we've trained people in the CFI, we've studied its feasibility and so on, but we haven't yet been able to do, we're in the process of trying to do research on how much of an impact does it have on any number of outcomes when we use it. Also, we should know what makes a good or bad, what makes it, what kind of patient characteristics, clinician characteristics, setting characteristics make for better or worse outcomes or administrations of the CFI, how to use it with interpreters, and then very importantly, how to use it in settings that have to do with team-based care rather than individual practitioners, where one person may do one part of the assessment, another one does another one does another, all as part of a team, and then they share information. What is the best way for that to happen with the CFI? And then issues of fidelity, how do you apply it in the real world without losing its fidelity, in incurring what's called drift, when you're actually, people are just using it in ways that wasn't intended. And unhelpful ways to have it, because if you discover better ways of using it, we definitely want to hear about that. Next slide, please. So in conclusion, next slide. Thank you. We propose that the CFI can be used with every patient, is person-centered to avoid stereotyping. We feel that it's been operationalized and is implementable. It should help to guide assessment and treatment negotiation and to enhance provider competency and service responsiveness. I'm going to stop. Well, the next slide, and maybe we can leave that slide up, shows you the links for how to access the CFI on the web. I'm sorry that I ran over. We started a little bit late, but are there any questions, comments, things you would like to ask about or tell me?
Thank you, Dr. Luis Fernandez. We have a few questions. So you mentioned that question 16 addresses clinician-patients relationships and concerns. Um, is that previously explored in the past help-seeking subdomain?
It can, but this actually refers, actually not usually, because what the 16 question has to do is with the care the person is about to start. So it's going forward rather than what happened before. So the question before, one of the questions in the third domain had to do with what was most helpful and not helpful of previous treatment. And there the person could say, boy, what was not helpful was my doctor was awful, and tell you all about the awful things the doctor did. That's very good in that past help-seeking section. Here we want to know whether they have any concerns going forward about the relationship they're entering into, the setting they're going into, any number of things.
Okay, thank you. So you mentioned that you studied some variables, including feasibility, acceptability, and utility, and you have some information on qualitative data. Have clinicians let you know some barriers that they might have faced while using the CFI?
Definitely, all sorts of barriers. We even have a barriers paper. If you Google barriers, CFI, Agarwal, do they have these slides, Doris?
Yes.
Great. So you'll see Agarwal's name. If you Google barriers, CFI, you will get a whole paper on the barriers. There's of all kinds. One particular one has to do with time. This is always a concern that clinicians have. A paper we're working on just now, we're almost done with for submission. Another barrier is lack of flexibility. So if, for example, this was in an inpatient set of units, if the unit is too rigid about you must do the CFI in the first 72 hours, no matter what the status of the patient, that was considered quite a barrier. As opposed to being more flexible, if the person can't answer within 72 hours, then it should be a week later or something like that. So there are a number of barriers that come up that are useful to know about.
Okay, thank you.
Sure.
Some people are asking, do you have materials available in Spanish?
The CFI is available in Spanish, but I don't know that there are research materials available in Spanish, meaning the informant and core CFIs are available in the Spanish translation of the DSM-5. Technically, the way this works is that the publisher of the DSM-5 has copyright over the translation. But if you're interested in the Spanish translation, maybe you could email Doris and she could email me, or somehow I can get you a copy. But essentially, the DSM-5, the book, has been translated into multiple languages. All those translations include the CFI informant and core versions, but not the supplementary modules. Those have been translated to fewer languages.
Okay, thank you. Another question is, did the clinical settings include community health centers?
Yes. There were different. If by community health center you mean community mental health centers? No,
mental health.
Yeah. Yes. Different settings had different kinds of. In the field trial, had different kinds of. They were all outpatient and in different countries, and many were what would be called community mental health centers in the United States, or were actually community mental health centers. Like in the one in New Haven is a community mental health center, literally.
Okay. Okay, so I think that's all the time we have for now, but I would like to thank you again, Dr. Luis Fernandez, for your presentation, and to our participants, again, thank you for joining us. Just to let you know, once we finish the webinar, you'll be redirected to complete a brief survey, and we appreciate you taking the time to join us. So thank you.
Thank you. Pleasure being here.
Thanks.